but in the interest of time, we are going to get started with our second panel. So we have a couple of guests who are going to be joining us virtually. So we're going to be switching back from our in-person team to our virtual team. And just as a reminder, in this panel, we're going to be talking about the North Carolina Community Health Worker Initiative and the rollout of the case referral management system. So when Pam brings us our mic, we'll get started with brief introductions. Dr. Spratt, do you want to introduce yourself?
Oh, hi, I'm sorry. I'm Susan Spratt. I am the physician lead for NC Care 360 implementation at Duke, which includes socialization and social drivers of health impact health, and systematic screening for social drivers, and connecting patients to resources. And I'm an endocrinologist by training, and I got to this work because diabetes is such an expensive disease, and even our patients who are solidly middle class are having trouble paying for healthy food and all of their medications. So that's why what led me, because I want everyone to be able to be free of diabetes complications.
Maggie, do you want to go next? Maggie, you want to introduce yourself?
Oh, sure. Hey, everybody, it's great to see you. I wish I could be there with all of you. And Graham Adams, I got your text. Our great buddies at the Office of Rural Health in South Carolina are amazing. So glad everybody's there together. Maggie Sauer, I'm the director of the Office of Rural Health. And I've been in the Department of Health and Human Services for 5 years. I do have a rural background, and I really think that a lot of the things we've been talking about are really applicable to all across the state and certainly for our rural communities. So I'm excited to be here, and I know I'm going to learn so much from everybody. Thank you.
Honey, you want to take it over?
Sure. What's up, y'all? Can you hear me? Honey Estrada, president of the North Carolina Community Health Workers Association. Super pumped to be here. I am a proud community health worker with over 20 years of experience in healthcare and public health. So passionate about this work, embodying all the CHW power. I live in Newton. I'm married. My husband is Mexican. We have 2 boys. We have a multi-ethnic household, and I teach Zumba.
Y'all, Honey is my partner in crime. When y'all hear more about her and the work she's doing, Honey, you're absolutely incredible. I'm LaQuanta Palmer. I'm the program director of NC Care 360 at the Foundation for Health Leadership and Innovation. Oh gosh, I can't wait to talk to y'all. This has been an incredible journey. Just can't wait to share.
Good afternoon. I'm David Reese. I'm President, CEO, Foundation for Health Leadership and Innovation. So I want to say thank you for allowing us just to come and spend time, not only with you, but with the wonderful folks that we work with all the time. And we actually get a chance to see them. And I know we've said this before, but during this period of us just sort of working through the pandemic, there are some of these things that we just sort of have taken for granted in the past. And so I'm thrilled that we're able to actually be here with you in person, in the room, have lunch with you, and we're looking forward to just sharing more.
I'm Heather Black. I'm the Vice President at United Way of North Carolina, and my role is over NC 211 and NC Care 360 for the United Way. And our role within NC Care 360 is that we have the team that manages the large set of out-of-network resources, over 13,000 resources. We'll probably talk about that a little bit. And then we have a hub of navigators that sit within our 211 call centers that handle high-touch clients. And I'll just piggyback off of what David said. It's been so rewarding to have this opportunity to sit down and talk about this work. When you're in the daily trenches, you don't think about it, and then you kind of have this moment and you're like, damn, we're doing some good stuff. So thank you. Thank you for giving us a chance to reflect on what we've accomplished.
Okay, so I'm going to be doing a little bit of running back and forth on this one, trying to manage our virtual guests and our in-person guests, so they have to talk into the computer. So we are going to get started with Mrs. Sauer's questions. So we'll come over here. So the North Carolina Office of Rural Health, which is housed in NCDHHS, is leading the state CHW initiative. This initiative is focused on building a sustainable structure for community health workers. It includes training and certification of community health workers. Why was it important to include community health workers in the state's overall infrastructure strategy?
So, boy, I could talk about this forever, but I think we'll start with the Community Health Worker Association. And more importantly, that community health workers have been doing this work for many, many years. And it's finally, we've had the opportunity with the pandemic to recognize not only the work that's so important by being culturally sensitive, authentically lived life, how it affects health. And so I would just say, as we looked back and looked forward in our 1115 waiver for the way that Medicaid transformation happened and so on within the state, our leadership basically said, we're not just purchasing health care, we're purchasing health. And so the reason for, including this as a really formative strategy is because we know that people have got to have people in their lives that they do trust, are trusting, to get them to those resources, and those connectors are probably one of the most important parts of how people can get to and maintain their health. So all of the resources and things that are available, we really have to rely on the community voice to make sure that people trust and can get to those resources. So it is a really large portion of what we do and how we do it.
Wonderful, and building off of that question, we want to dive a little bit deeper into how the community health workers fit into the actual infrastructure that is being built. Some of the things I would love to know is how community health worker service costs are being built into the value-based model, who employs them, how are you engaging the Community Health Worker Association?
Yeah, so thank you for those questions. I would say, just so that folks kind of have some perspective on this, there was a group of folks way before the pandemic, 2014, started having community engagement discussions. And Tish Singletary here at the state led that. And so that happened in 2014. There was a lot of thoughtful discussion about how communities should be engaged, not just from an institutional piece, but also from the community piece. So really when one of the things that the Office of Rural Health did was we really believed in the model and decided we wanted to hire a community health worker coordinator, and Tish came over and helped us do that. But the more important part of it is that they created a blueprint about how this work should happen in the state. And it's a collective voice, a collective part of this input. And so we use that as a way to kind of move forward. So the Community Health Worker Association with Honey, in that leadership has continued to evolve and support the work as we're going forward. I would say, and Honey may talk about this later as well, but you can see, I don't know if you can see my screen, but the Medicaid regions that are outlined on this map are ways that we are trying to look at meeting the needs of people in those particular regions. And in Western North Carolina, it's very different than Eastern North Carolina. So as we're beginning to look at those cultural differences and needs, we're trying to look at that on a regional basis, and that's baked into kind of the Medicaid transformation model. When you look at Medicaid reimbursement, and I would say not just Medicaid, because we know some states are actually using Medicare ACOs as another way of building it into kind of that collective payment. Presently, we've used the COVID dollars to employ a number of community health workers across the state, over 500 in each county across the state. That funding will come to an end at the end of December. And so really what we're talking about doing is continuing to bake into this infrastructure the work of the community health workers through a PMPM payment that the PHPs and others who are working through Medicaid payment and who the state works with to create those services so that they could employ community health workers. We're working really hard also to determine beyond just kind of the medical drivers, the medical employers, if you will, how community-based organizations can continue to be engaged in that work to make sure it stays authentically based in the community. So the drivers and the ability to sustain that work, I think, will come from a number of opportunities. Right now, it's being driven by baking that into our policies at Medicaid, looking at what we can do with Medicare, and certainly, trying to, it is recognized within the Medicaid 1115 waiver and the work that the Division of Health Benefits is doing with Medicaid to sort of socialize and memorialize this in that work.
Thank you. You talked a little bit about a long-term payment model, but are there other important factors to create sustainability for the community health worker infrastructure?
Yeah, there are a couple things probably, and I'm gonna talk about three, but there's certainly more. The first one is a strong community health worker association. And I don't wanna step into Honey's, what she's gonna describe, but the ability to create a training base and certify folks so that they have, if they want a certification, they can have that, and to create an educational system that sustains it. And so one of the things that we have continued to do in the state is try to look at, what are all these different pieces of things that need to be sustained to support this incredibly important workforce. And part of that is training and certification. So the community colleges have engaged in this. It's going to be built into their infrastructure, the whole certification process and core curriculum. There's core training, specialty training that AHEC is doing with us. And then it's really how do you maintain that and help people understand how to integrate that within their workflow in a meaningful way. So the community health worker is one of those partners, those primary partners. And then, as we're looking at Medicaid integration and additional funding, it is baking it into as many policies and as many recognitions of good health and good health support that we can do that. And NC Care 360 is a big part of that in terms of helping us quantify that, as well as create a system where we can track where those referrals are and making sure they're being closed. So, and the evaluation piece, I think, is really important. All those pieces are really come into play in this.
Thank you, Maggie, and if you'll stay with us, we have some questions for you at the end that I am now going to ask. Honey has a couple of additional questions about the community health workers, and the first is, what is the North Carolina Community Health Workers Association's key role in the overall state initiative?
Thank you, Melissa. Hey, Maggie. Hey, Maggie. She's waving at me. Okay. I see you. All right, so at the association, it is all CHWs all the time. And I think that the most important thing when we look at CHWs, when we think about this workforce, is really elevating the voices of CHWs and advancing their voices. These are, again, if we look at the workforce, it is predominantly women of color, and women of color who have been doing this work for decades, who are highly experienced and highly in tune with local communities. So we don't have to question whether or not they know what's going on. They know what's going on. They're the ones that the communities come to when there are issues, when there are problems, when there are questions. These are the champions in the communities who are doing this work. And at the association, we are highly invested in advancing this community-based model. As we look at the workforce, one of the first priorities was really formalizing and standardizing training and certification for the workforce. Over the past several years, we've worked really hard. So there, as Maggie alluded to, there were efforts with the state to really push forward with building what we call today our Standardized Core Competency Training, or SCCT. I'm so proud because this curriculum was developed by community health workers. So this is really community health workers leading other community health workers. And this was really us listening to the voices of community health workers from the very beginning, since 2014, when all of these initiatives started, again, honoring the fact that CHWs have been doing this work for decades, even before 2014. Since that time, we worked really intently and intentionally to make sure that those voices were at the table every step of the way, and that we were honoring those voices every step of the way. We heard from CHWs who said, yes, we want certification. Yes, we want standardized training. And the first step was, of course, offering it through the community colleges. That came from the voice of the CHWs who said, this is where we want it. This is where it's accessible. With the association, we are in the business of removing the barriers for this workforce. Again, a workforce that is predominantly Black and brown, a workforce that comes from disparaged communities. We have a large majority of our workforce who are Spanish-speaking women. We've worked very intentionally to make sure that we can provide a curriculum that is offered in Spanish at 2 of our community colleges. That was such a tremendous win for us. I know, right? Yeah, we can celebrate that, right? Right? I mean, and so these are Spanish-speaking CHWs who are leading other Spanish-speaking CHWs. And we'll talk about all of that, one of the biggest wins in a little bit, but that is changing the game. It is changing the dynamic for a workforce who have never had these opportunities before.
Never asked the question.
Right, exactly. And so, this was an opportunity for us to change that game for CHWs living in North Carolina and then moving into certification. What does that look like? How do we do this? How do we do this in a way that is accessible, that is equitable? And so again, being very intentional to say, when we talk about certification, we do not want to say, okay, once you complete SCCT at 80%, so it's a 96-hour core curriculum training. Once you pass that, you can submit an application for certification. We're not asking for you to take another test. We are not asking for you to submit high school diploma. We're not asking you to submit Social Security information. We're not asking for any of that because we believe in you and we believe the fact that you have the expertise as a CHW to lead this work inside of your communities. You know it better than we do.
Yes.
You don't need me to say or validate the fact that you're already doing this work. I already know you're doing this work. So it was really a way for us to remove those barriers for this workforce. It's a way for us to speak the language of the system through certification and then teach the system how to speak the language of the community. I can talk all day about this.
And we wish we had time for you.
Yes.
So our next question for you is, what have been the biggest challenges in expanding this work?
Whew. All right, Maggie. Here we go. Maggie knows this, but we've had some really tense conversations. We've had some really difficult conversations. And I'm going to be real with y'all because I don't know how else to be. We are talking about a power dynamic shift. We are talking about turning the tables here. If we are wanting health, y'all, the community has the answer. Right? Y'all know that. I'm preaching to the choir. And so instead of us saying, okay, let's build these programs for the communities, this is Public Health 101, y'all know this, come on now. It is now to say, okay, let's have some difficult conversations, just as the first panel alluded to, as they talked about. This was an opportunity for us to say, okay, let's name this big elephant in the room. Let's look at it square in the eye. We know what the data tells us. We know that the disparities exist. We do not have to go back, as Deanna alluded to earlier. We can't hide behind the data anymore. COVID showed us that. So how do we take what we know and what we learned through the pandemic to change the game? And it was us really having some difficult conversations to say, we're not doing it this way. If we are really going to achieve positive outcomes, this is the way we have to do it. We have to start listening. We have to start allowing the leaders who are already doing this work to come to the table and show us how to do it. So yeah, so some truly difficult conversations, Melissa.
But sometimes those difficult conversations yield our biggest successes.
Absolutely, yes.
So can you tell us about those successes?
Oh man, there's so many. I think that, so we formalized certification earlier this year, like February or March-ish. And so just in a very short amount of time, we have over almost 500 CHWs who have been certified, right? You can clap, yeah, you can celebrate it. And that is a state certified or a state recognized certification. When I talked a little bit about our Spanish speaking curriculum, these are individuals from the communities, these are CHWs from the communities who have never graduated from anything before. And they are graduating from a program, and the pride that we see in them and the excitement and the celebration that they get to have with their families and the conversations we at the association get to have with these individuals when they get their certification and they call us to say, I got my certification documents and I showed it to my boss and I'm gonna get a promotion and I'm gonna get some more money.
Right.
Y'all, again, we are changing lives. These are people who, again, have come from disparaged communities. We are changing the game for them. You talk about successes, I'm here for it.
Thank you, honey. I can feel the passion right now. So our next group of questions, I'm gonna let LaQuana, David, and Heather decide who answers which ones. So my first question for y'all is, as part of the infrastructure building, the state chose to implement a single case referral management platform that you have named NC Care 360. Why did you decide to go with a single CRM versus trying to connect the existing platforms that were in place?
So I'm gonna start it off by kind of, again, level setting NC Care 360 and the work that we do. And then I'm gonna hand it off to Heather because Heather is the veteran on the team.
Along with Dr. Tilson.
Along with Dr. Tilson. But when you think about NC Care 360 and the work that we're doing with Healthy Opportunities, I think there's a lot of confusion sometimes that happens with the work that is going on there. So when we think about NC Care 360, we have what we are administering, what we are managing is the core work of NC Care 360, meaning that anyone in the state of North Carolina who identifies a need is able to work with a provider to help them connect to resources. So that's one. Then we have an additional piece that we're working with Healthy Opportunities pilots, where we have an additional, what we call additional function that helps us to work with this pilot work across the state that you heard in our first panel. So it's important to make sure that we keep that in mind because sometimes when we're thinking about our referral system and the coordination that we do, it is work that is just happening just in Medicaid. No, it is for anyone in the state of North Carolina who identifies a need, who's working with our providers, they can then be able to connect to this. And we have an no wrong door approach, meaning that if you are in a health system, if you are at a church, if you are at an educational institution, if you are working with what I call an auntie at a community-based organization, you are able, with our community health workers, able to connect to NC Care 360 in our community. So just with that all in mind, and when we go to more work, that's something I wanted to make sure that you keep in the top of your mind. building this infrastructure is not just for one system. You're thinking about building this for multiple systems across the state. And so Heather, I'm gonna hand it off to you.
So, it's an interesting question because I honestly don't remember it being a very intentional conversation. Well, in the sense of it was intentional in the sense of, yes, we wanted a single referral system, yes. So I take that back. So yes, we wanted a single referral system. And it was, I think, again, not striving for perfection, knowing that we had to start with a coalition of the willing and that others would come. And I think it's important to say, we still don't have everyone in our state fully on board. We still have 2 of our major health systems that are using other systems. I still believe they will get there. I think, again, you start with a coalition of the willing, you show the success, you show the strength, and you show the power of it, and others will continue to join. As far as the name NC Care 360, that literally was just, we should probably come up with a better name than Managed Care Platform System, Coordinated Care System. So that's how that came to be. But, I think the functionality of having a single repository of resources, that was a key pillar of what we knew we wanted. I remember distinctly conversations with Secretary Cohen about, there's so much energy being put into creating all of these separate resource databases and maintaining them, and the pressure put on CBOs to maintain their data in so many different places. So who's already doing this work? We were doing that work, and we were so grateful that she recognized that. So that was one piece of it. And then again, we know that agencies, CBOs, HSOs, whatever we want to refer to them as, we're already talking to each other in so many different ways. Some of them through a Rolodex, some of them through Excel spreadsheets, some of them through emails, some of them through case management systems. It was already happening. This functionality was already happening. It wasn't changing the workflow. It was giving them a tool to use to manage that workflow, to enhance that workflow. But it is still a change management process. You are still asking people to do the work they do in a different way. And we all know that is hard. It is hard for the little nonprofit who is a 2-person shop. It is hard for the big nonprofit that has 50 people working there. So either way, you are still having to go through a change management process and get that buy-in, understand their workflows, understand how you can integrate or change this process, and getting them to let go of things that maybe they've done in the past and embrace this new way to do this work.
So my next question is about FHLI more broadly. So why is FHLI well poised to do this work, and what is your specific role in the implementation?
So first off, I thought you'd never ask. All right, so thank you for asking.
You're welcome.
So let me just sort of define FHLI so you understand the entity itself. 40 years old, organization really committed back to health and wellness and health equity for all North Carolinians across the state, in particular really with the focus back on our rural communities and really supporting our rural communities. We have several components, big, I think, sort of pillar programs, as you might say, around oral health, rural health, as well as behavioral health. For us, there is this sort of a key question, which is how do we get to the root causes of health inequities? And then how do we actually support systems as they realign themselves? And that takes us back to, I think, one of the part of the conversation that Dr. Tilson was talking about a little earlier, which is really about alignment. And this process being about getting the right folks on the bus, getting everyone in the room, right, sitting at the table, and then having the alignment so that it all begins to sort of function. And so what we've seen when you think about all the many projects that you've worked on throughout your career is you have the best intentions. You have what you think are actually the best players on your team, but you continue to fall short. And we fall short because who's on first? I'm not quite sure, but maybe we both should be on first. This is about really making sure folks are sort of in the places where they need to be as we move towards one large goal for the state of North Carolina. So when you ask the role of FHLI, I mean, we're the administrator. Part of our job is to help our broad team, this collaborative process, really begin to think about who needs to be on second, who needs to be moving to third, and who's at bat next. And I hope that there was some baseball fans in here and figure this out. All right, I mean, we're getting to like October's around the corner, so I mean, playoffs are happening, but but that's part of our role. There's this other, I think, really important aspect to this, is there's a public-private partnership,
Right,
right?
that's right.
And this was like really, really smart.
Yes.
This was super smart. And so Secretary Cohen, Dr. Tilson, thinking about how do you actually take this amazing idea and not let it sit back in state government? How do you actually bring it back to the private sector, which allows us a lot of different options here, right? Also shields it from, the political winds of, who's here, who's not here, when do folks leave, what their new thoughts are. This is, I think, as we like to think about it really, the model for how we begin to sort of realign some of our goals just around health.
Can I add something to that?
Yeah.
I want to add one thing to that along the same lines of having been in so many of the early conversations with CBOs and other stakeholders, and it was like, oh, so this is just another thing the state's rolling out that they're going to tell me I have to use, and it's not going to work, blah, blah, blah.
Yep.
And just, I am a recovering state employee, and but to be able to say to them, no, it's different this time. This lives in the private sector. We have an amazing partnership with DHHS, and they are advising and guiding some of this work. It does not live in state government. The funding is not sitting there. Was a true turning point for people to go, okay, I can trust this. This is different this time. I can believe in this. It's really critical. You need to have something like an FHLI that sits in the middle there. That's also kind of the traffic controller, the ringmaster, whatever you want to refer to it as. I think that's a critical piece to find something that is nonpartisan, public foundation type of thing, not a vendor. Needs to be something neutral.
So I want to go back to the single platform idea. And specifically related to that single platform, what are the challenges that you felt like a single platform would help you solve?
So I'll say that when you're thinking about a single platform, and keep in mind, when we chose the platform, there were numerous, but this was an existing platform that was already in the state, that was already working with our veterans and our armed services. So this was an existing platform, and the reason why we chose to go in this direction is because we wanted to find a way to find some consistency. In addition to that, a way for us to be able to align and collaborate. But we also wanted to make sure that it was secured, because a lot of security has come up already. You want to make sure that it's HIPAA, FERPA, add all of those different letters that we all know so well. But to do that and make sure it's a way that is trackable as well. I mean, I can tell you, I come from the world of working with HIV prevention and being able to work in a clinic and connecting many of our clinics to, a number of different resources that are out there in the community, and having that big notebook that you are just flipping through, trying to make sure you find the right one, and then getting to the point where you don't know whether or not, when you give that person that resource, whether or not they were connected or not. So when you're working with a single resource, and we focus a lot on the platform, but this is a network. This doesn't just start with the platform. This is something that starts before then. So you have our community health workers who are at the table. We have our functions with our navigators who are able to, just in case there's a hang up on the platform, they can then be able to go even further with some of those complex cases. But when you keep all of that in mind, you have a single referral platform that you can use, that anyone across the state can pick up and kind of take forward. It's incredible, because you have this way of having interoperability across the state where you have a shared information system.
Thank you. So my next question was about the process of rollout. So what was the process for rolling out the platform across the healthcare systems and CBOs? And I'd really love to know what were the requirements, and were there incentives for using it with the CBOs? What information did y'all share across the partners, including describing NC 211? And in-network versus out-of-network.
Yeah.
Mhm.
You want me to start with that, or?
You can start.
I'll start a little bit and then-
Okay, go ahead.
So, couple of things. At the very beginning, we did a lot with what we called influencers. So going into a community and deciding who are the leaders in that community, probably the people in this room. When you go back to your community, folks are gonna listen and know, what did you learn today? What could we do here? So we identified those stakeholders in the community and they became our influencer circle, and then met with them and had them host larger meetings with other groups. And that was really the model. That was great until COVID happened. That made it a little harder after COVID. I think that's the other thing is to keep in mind is doing all this during a pandemic really, the flexibility of this team is pretty amazing, of our state and this team is amazing. So that was one model that we used that I think gave us some of our early success. Then during the pandemic, really just kind of put the gas pedal down and really just worked very aggressively to get some saturation in every county statewide. That was the goal, was to try to find some saturation, and looking at our NC 211 referrals, we have what we call 80-20. 80% of our referrals are made to a set of 20% core resources. So looking at where that those 4 pillars that Betsy and Amanda talked about, food, housing, transportation, interpersonal violence, and toxic stress. So looking at those high need areas and saying, okay, these we know are the ones that we need to get on. So let's talk in-network versus out-of-network. As I mentioned, there's a resource team housed at NC 211 that maintains the entire kind of world of resources for the state. That's about 13,000 resources in North Carolina. So large set. Those are not all on the platform in the sense of accepting referrals and doing the referral activity. They are all accessible through the platform as an out-of-network referral. So if you're going on the platform and you want to make a referral on behalf of your client, you first want to see if there's something in network, something that has signed on, gone through the training, said, yes, I want to use this platform to manage my referral activity for my clients. So those are considered in network, and LaQuana can speak to the volume of that. So there's the in-network versus the out-of-network. So if you can't find an in-network resource, or maybe you have found in-network, but you also just want to, as a safety net, give your client also an out-of-network, you can add an out-of-network resource as well, and that comes from the 211 database. An out-of-network referral is still going to be your traditional information referral, where you're giving the client the information and saying, this is a food pantry, they're open on Tuesdays from 2 to 5, you should go there then, this is the information of where they are, you should take, your electric bill to show that you live in the zip code, something like that. So you're putting kind of the responsibility on the client. What's different is in-network, and that's what LaQuana can speak to of how that works.
So when you're thinking about in-network, and I think it's absolutely incredible, it is again going back to that closed loop referral system. So right now we have almost 3,000 closed loop organizations that were on NC Care 360. In addition to that, over 7,000 programs. So if you think about all of this, this is within the network of NC Care 360, meaning that if you are a provider, if you're a community health worker, you now can go in using NC Care 360, these in-network providers, provide a referral to any of those different resources that are listed there, and then be able to track exactly where that resource goes. So that is what we consider in-network. Again, it is a wonderful functionality that we are still building. One of the key things, and we'll go over it in our different challenges on what are some of the challenges to use some of these in-network providers, is making sure when you're going through a pandemic and staffing then starts to disappear, what happens to those referrals? So we'll go into a little bit of that, but just to think about exactly, what it means to be, in network and using the platform, is being able to have that interoperability and being able to talk to another organization. Think about a provider that is working within an institution and you've got several different programs that are there and they never talk to each other. But you can use something like an NC Care 360 and be able to talk right within your org to be able to serve a client that has a need.
Thank you. So what has the response been from the healthcare systems and the CDOs as they're using the actual referral system and platform?
So some of the things that we're hearing from our healthcare systems, and I wanted to make sure I wrote down some things that I heard from them, was the fact that when you're working with a health system, they're happy to know that they have something that they can use as, again, interoperability. It's a way to be able to work with those community organizations that they know, like Honey said, they know what is happening in our communities and they know what resources that are needed. And the fact that they now have a platform they can use to be able to connect with those community organizations and connect those clients and patients to those different needs, they think is wonderful. And I think that Dr. Spratt is on and she'll be able to speak to some of that work as well. But in addition to that, it's making sure that they know that they can investment. It's an investment. When we're working with our health systems, one of the key things that we're doing with our value proposition and thinking about what is a value add, it is being able to explain to them that, hey, this is something that's going to help you with your workflow. It's going to help with making sure that when that person leaves your chair, that you know that you were able to connect him to a resource that was available in the community. So those were definitely some of the things that we saw with working with our health systems, with being able to share some of the great things that are happening with using NC Care 360.
And as LaQuanta alluded to, the next thing I want to know is what were the barriers and how have you addressed them?
So when you think about the barriers, and I think David's going to touch on this as well, as you know, we saw a couple of things. When you're thinking about our CBOs and their staff capacity, you have these organizations that maybe have one or two people that are working there, and sometimes there is a lot of turnover that is happening there. So that's something that you have to keep in mind when you're doing this work. The next thing is making sure that you know that each system has a unique need. So if you're working with a health system, if you're working with a CBO, you're working with an educational institution, whichever system, choose one. They all have a different way of doing things. And so when you're going in and you're working with, we call our configuration, where you're going in and you're working with an organization to help them with onboarding onto the network, you need to do some readiness with them to ensure you know exactly where they are. And I think Dion touched on that a lot, to make sure that you can work through that process. The next thing is just thinking about limited resources. We already have communities that are already strapped for resources. So making sure that resources are available in the community when you want to connect them. And then the last thing is just thinking about technology and broadband access. When you have your rural communities, and I think, again, our partners in the West spoke to it, but also in our Eastern. When we think about North Carolina, sometimes we revert right to the Triangle region, where we have Raleigh, Durham, and Chapel Hill. But there is so much of North Carolina outside of that that is a very rural community. And so when we're thinking about that community and not being able to connect to those technological resources, having a digital divide, those are solutions that you're going to have to think about as you begin to roll this out. David.
So thank you, LaQuanta. I want you to reflect back to like your relationship with community-based organizations, right? Like think about the person that you know that actually runs one. I want you to think about their infrastructure. I want you to think about their staffing. I want you to actually think about their client base, right? I mean, the folks that they work for every day. And then on top of that, I want you to ask yourself the question, were they actually meeting the need of everyone that knocked on their door before the pandemic? And think about, well, if you have got 5 fingers, how many of them were actually meeting the need of everyone that knocked on their door? And then now I want you to fast forward and I want you to think about what's happened to our workforce throughout this pandemic. Everyone's heard about the Great Resignation, quiet quitting. I mean, you choose like whatever you want to talk about with it, but think about that industry and then think about what we know what happened during COVID. Well, during COVID, all of a sudden, there were all of these other issues which were already there, but the rest of the world kind of acknowledged that these are issues that were happening back within marginalized communities across the state, across our state, across your state. And when we start thinking at that point, well, how do community-based organizations during a pandemic deliver high-quality services when they were already handicapped and now they're dealing with some of the challenges that every other business across America is dealing with? That's the barrier. And we talked a little about it a little earlier in terms of like investment, right? And investing back in capacity. And that's where like there's this, if you take away like a couple things, don't just take away one, take away a couple things, but really thinking about the CBO network and what investment back into capacity, their capacity looks like as we think about health. And so if we do not invest back in their capacity,
Are you investing back into health?
are we investing back into health?
Good food for thought. So I'm going to transition to a couple of questions for Dr. Spratt. So Dr. Spratt, what was Duke's response to the rollout of the city platform? Was it something you were already using?
So our first, response really goes back to, a few steps before that. And that is, in 2016, we had a committee look at how are we going to screen for social drivers of health and how are we going to connect patients. And we actually, two of the people on the committee, not me, had submitted a grant to build a care coordination platform. And they actually, when they heard about NC Care 360 and heard that it was coming, they withdrew the grant that they had already written because they wanted to be part of the state solution. In 2018, we put in our EHR into our social history section, questions for social drivers of health. And at that time, I went around to multiple clinical areas and said, put this in your workflow, put this on your screening paperwork. We need to ask these questions. And part of the very first step of this process is socializing the idea and getting acceptance that social drivers of health impact health, and that the medical community has a responsibility to help patients get connected. Not everyone believes that. Not everyone believed it back then when we first brought it up, and not everyone believes it now. So unless you can get everyone on your page, or the majority of people on that thought, you're not going to easily move forward. And when I say everyone, I'm talking about front desk staff, I'm talking about nursing staff, I'm talking about providers. So we implemented the social history section, and one of the most important things about this is that it's discrete. So I can tell you how many people screened positive for food insecurity in my Duke Endocrine Clinic in South Durham in the last week, and and that information is viewable for everyone. So if they show up in the ER or a different clinic, you can see that that is a social concern. It's highlighted, it's very easy to find. And so that was really important to us. But, I didn't get a lot of people implementing the screening. It was kind of like they found out about it, they might put it in this section. But by the end of 2020, we had data on 20,000 people. And so 20,000 people had been screened. We had identified 2,000 people with food insecurity. With the advent of NC Care 360, we initially thought we were only going to get 185 licenses. So I told everyone who wanted a license they had to submit a plan for how they were going to systematically screen and use our social history section. So I had 5 clinics commit to that in January 2021. We ended up getting an enterprise-wide license, and that might be the key to why Duke has more referrals than any other hospital system in North Carolina. But we had these very flexible workflow plans to collect social drivers of health. The Roxborough Road Peds Clinic was using welcome tablets. Some people were verbally screened by their nursing staff. Some people were doing paper. We sent the MyChart questionnaire, which is our patient portal questionnaire, to every patient once a year in the clinics that we designated. And we're now currently live with systematic screening for social drivers of health in over 32 clinical sites, ambulatory wise. The other thing is we chose to test this in the ambulatory environment. UNC, I think, did case management, and WakeMed did ER. And that might be another reason, because the inpatient management and case management, they were totally inundated with COVID. And every time we personally tried to start on inpatient, we couldn't because there was a COVID surge. So the first step is really figuring out how to systematically screen for social drivers of health. So we've increased the numbers of patients we've screened from 20,000 to 100,000 in the past 18 months or 19 months. and we implemented NC Code 360 incrementally, and then I said, let's just put it in the system for everyone. But people don't usually find things unless you are really doing a campaign for this is how you use NC Code 360. So we sent more than 1,000 patients last year had referrals in NC Code 360. And this is what we learned. We learned that we need a key person to help be that person who's gonna put the referral in. I naively, probably because I'm a physician, I naively thought, oh, this will be easy, anyone can do this, anyone can do social resource allocation. But it turns out that's not true, you have to have training, and your MD and your RN license does not provide that training. We actually have undergraduate students doing some of this work, but they get 20 hours of training. The community health worker role is super, super important. And without having, whether it's a population health nurse, a community health worker, a social worker, or one of our trained students really help me, I'm gonna be responsible for this referral inside NC Code 360, it doesn't work as well.
It's true.
So, Dr. Spratt, I want to leave some time for questions, but as we gather those, I wanted to ask you one last quick question. You talked about having to shift our mindset and how we think of the healthcare and healthcare providers' role in social determinants of health. Were there other major changes that the healthcare system had to make to be able to implement this work?
Well, yes, and some of them we didn't make initially because this was a pilot and we were trying to figure out how are we going to do this. And so one of them is building our workforce for handling those referrals. So for my clinic in endocrinology on Duke campus, we have a social worker. But for my other 3 clinics, which don't have social workers and live in a more affluent area, we're still getting 10 to 12 people a week who need social resource help. And so how do you help them when you don't have enough people to justify one social worker sitting in your clinic? So we're moving to a centralized social support model at our population health office. And we've hired a social worker and we will be hiring community health workers to help me at those referrals. Duke Primary Care, which is it has 52 clinical sites, uses population health nurses, and I want to tell you how they pay for them. They pay for them because they get money through annual wellness visits. They do annual wellness visits 75% of the time. 25% of the time they follow up on social drivers of health referrals for anyone that comes in. And so that's how they pay for that model. But what we're finding, and I just want to make sure that this is said, is, Duke, because we're an urban area, Durham is an urban area, we are not participating in healthy opportunity pilots right now. And I think the rural areas definitely needed it. I'm jealous of them for getting the healthy opportunity pilots before we did. But we're struggling with figuring out how do we support our CBOs who need financial help and not flood them with referrals that they do not have the capacity to handle. So that's the next big step is financially supporting our community organizations in a sustainable way.
Well, my final audience question, sorry we only have time for one, you had really good ones, but we'll follow up with those in the closing documents and get answers from our friends in North Carolina. How do you manage those different capacities and technology abilities of the community-based versus the healthcare organizations?
I'll start with talking about we currently have a what we call our health equity grants. And so right now with using those health equity grants, we're doing exactly that. We have 2 grants that we have put out to the community, which was one for finding a network support agency that will help with some of those technical needs and some making sure that we have the capacity building support to make sure we're building up the workforce that is using NC Care 360 and making sure that they're able to use and utilize the network. And then the second thing is making sure that we had community organization grants that went out, and we're talking about $100,000 that went out to a number of community organizations to again help them with building up that capacity. So whether it was training, whether they needed additional resources there was a number of things that we had on our list, but one of the main things they had to make sure they did was onboard onto NC Care 360 within 60 days. So in order to do that, you have to make sure you had the additional support to be able to do that. And we want to make sure we expand this. This is what we call a proof of concept project that we're doing, but we're hoping to see more of this across the state. These types of projects are critical to make sure that we are building that capacity support.
I want to add to that though. So I think it's really, really important in this work that you're clear with your community and your stakeholders. You're not creating new resources.
No.
Right?
That's right.
That has to be clear in your messaging. I always tell people, 211, we don't have a special resource tree that we keep in the bag, that we shake out, and all of a sudden all the housing appears. Same thing here. So you have to make that clear. There are a couple other enhancements that are part of our platform. Agencies have the ability to turn it down and say, hey, we're out of stuff. We don't have anything left. Don't refer to us right now. Or if they have it, they can, turn it up and they can accept more referrals. But I think it's really, really critical that people have to understand we are not creating more housing, more food, all of those things. And it's hard to get folks to sometimes want to do this, but there's a real value in tracking those unmet needs, right? We all are resistant to that because we don't feel like we're helping anybody. But if we can help, the leaders in our state government and the leaders at our legislatures to have that real data, and we're not doing it in silos and we're doing it on a coordinated platform so that we can really put data behind the anecdotes. We all know housing's a huge issue, but if we can actually show it in a coordinated way, there's a real value to that. And we're not going to fix that in a few months or a year. It might take 5 years, it might take 10 years, but I think that that's the other piece of the messaging that is really critical.
Very good.
Well, I want to.
I agree with that.
That was Maggie, right? Yeah.
Well, I want to close with just one piece of advice from each of you. If you'll just go down the table, and then we'll get to the people on the screen of what you want us to carry forward in this work.
Okay. I think really is, this is coming from me as a CHW, lead with authenticity.
Yes.
So many times we get bogged down in checking the box. Right? Y'all know what I'm talking about. We're checking the box. What are we really trying to get at here? When we look at health equity, at the center of it is racial equity. I recognize that as a woman of color, my skin is not as dark as Laquana's. And I have privileges that she does not. Lead with authenticity. Understand what your privilege is in this. How do you use your position to influence and impact change?
Mine is community investment. You have got to invest in your community organizations to ensure that they are prepared and ready to be able to accept a lot of the referrals and needs that we're seeing across our communities. So finding a way to create a model in your state that helps with those community investments. And borrow from us. Look, we are working through, we are not perfect, but you don't have to recreate the wheel. If there's something that you want to know, you got a damn good panel up here that will help you with kind of figuring this out. The first panel and the second one. So my biggest advice is don't feel like you've got to start from scratch. Use your neighbors. We'll help you.
That was good. But I think maybe my advice is somewhere along the lines of what Laquana said, and I think also what Honey said. And I'm going to frame it a little differently, though, in terms of like your action steps. Is you heard us talk a little early in the first panel about it didn't need to be perfect, but you got off the sidelines and something happened. And then there's also pressing the easy button. Like there's an easy button. use the easy button, right? I mean,
Right.
there are all these folks around you back in your community, and those folks are at a ready stage, and they're part of that easy button.
I think it goes along with what Honey said about being honest. When pieces of it don't work, don't pretend like it does. Be honest, because they know, right?
Yeah.
And so, there were meetings along the way and conversations where people punched holes in it, and you have to acknowledge when somebody has found the flaw and listen and adjust.
That's right.
And I think also trusting and knowing what you have in this room here. You have a United Way Association, obviously, I always call it my United Way home. And you have a 211, so don't recreate what you already have. I think we often, as nonprofits and as CBOs, we think we don't have it. We have it. You have it right here.
Dr. Strack?
I think many of y'all think I might be too honest sometimes, but, this is a work in progress. The vision of NC Care 360 is phenomenal. It's absolutely incredible. And we are getting there, but we're still working on it.
That's
And, I think for every clinic that I can get to systematically screen and to find a workflow to use NC Care 360 is a win. And then to advocate for resources for our patients, because I do think it will impact their health.
Maggie, would you like to share advice? One piece of advice?
Sure, so, if anybody got anything out of this presentation is, I think, there were a lot of people who shared the vision about how important this work is, and were willing to step up and step in a variety of ways. So there's, one of us could have never done, all this. And I would just say, looking at my colleagues that were there in the morning panel, and talking about what all of that looks like, being willing to be authentic in your interactions around what's needed and thinking about the possibility, not the impossibility, of what can happen and what everyone brings to the table. And you've heard us talk about so many partners who have been part of this to make it happen. And I think there's a lot of opportunity. I mean, we could all say, you can't do it this way, you can't do it that way. It's about, let's get to yes, and let's make sure that the people who are there are the ones who are actually able to give voice to what's needed. And I know that sounds a little ambiguous, but I do think when it comes down to it at the end of the day, people have talked about payment systems, and that's good, whether we like it or not, that is gonna drive this work. And I appreciate the fact that leadership felt like this was important to bake it into payment models. And again, whether we like it or not, data is gonna be really important to make sure that this is not just treated as a project, but as the way services should be delivered. So,
Thank you, Maggie. So I want to thank this panel and the previous panel once again. Y'all did a phenomenal job and had so much insight. Thank you for coming all the way from North Carolina to be here with us. So one last round of applause.